Okay, let's unpack this. Have you ever heard of TMJ, the temporomandibular joint?
Mm-hmm.
It's that tiny, incredibly complex hinge connecting your jaw to your skull.
Mm.
And when it acts up, wow, it can cause a world of pain and dysfunction, everything from clicking and popping
Right.
to locked jaws and even relentless headaches. Today, we're taking a deep dive into the truly cutting-edge surgical techniques managing these often debilitating disorders.
Yeah, and what's truly remarkable is how much the approach to TMJ disorders has evolved. We've gathered insights from, well, a whole wealth of sources, detailed medical texts, clinical observations,
Right.
to help you understand arthroscopy and arthrocentesis. These are two minimally invasive procedures that have genuinely revolutionized how surgeons diagnose and treat these conditions.
Okay.
Our mission today is really to distill those vital nuggets of knowledge, give you those aha moments,
Yeah.
and help you grasp this intricate world of TMJ care without feeling totally overwhelmed.
Exactly. So by the end of this deep dive, you'll walk away not just informed, but with a real understanding. You'll get what it means to go inside the joint, why these techniques are so valuable, and what a patient's journey through this specialized treatment actually looks like.
Right.
So before these advanced techniques came along, surgeons and researchers, they really focused on fixing structural problems in the TMJ, right? Things like a disc being out of place or issues with the bone itself.
That was the main focus, yes. But our sources reveal this profound shift in thinking.
Okay, what kind of shift?
Well, the biggest breakthrough, I think, was learning to tackle TMJ by first addressing the chemistry of inflammation within the joint space.
Ah, not just the mechanics.
Exactly, not just fixing structural issues first. This radical shift has often made structural surgery, if it's even needed, a secondary, much easier step. It profoundly reduces pain and boosts mobility.
That makes sense.
Imagine having a joint that's inflamed and painful. Getting that inflammation under control first makes everything else much more manageable.
Now, this next piece I found genuinely surprising. Most of us would probably assume the simpler joint wash, the arthrocentesis, came first.
You'd think so.
Yeah.
But our sources reveal this fascinating historical twist. It actually evolved out of arthroscopy.
Really? How did that happen?
Well, surgeons were faced with limitations like maybe not having the specialized equipment yet, or poor insurance reimbursement for the more complex arthroscopy.
Okay.
So they started exploring joint lavage, just washing it out and manipulation instead. It was almost like a creative workaround that remarkably proved incredibly effective on its own.
Wow. Necessity being the mother of invention there.
Pretty much. So with all this technology and evolution, what are surgeons actually trying to achieve with TMJ arthroscopy? What are the goals?
Good question.
Our sources highlight clear objectives: getting an accurate diagnosis, number one, then restoring jaw function, significantly reducing pain, and diminishing that joint noise, the clicks, the pops, all through a procedure that's minimally invasive, safe, effective, and importantly, can be repeated if needed with good long-term results.
And you mentioned something about the joint environment.
Yes, it's also about shifting the joint's internal environment from a destructive catabolic state to a healing anabolic one, essentially preparing it,
Okay.
making it more receptive for any necessary reconstruction later while minimizing bleeding and scarring.
So how do doctors decide if this deep dive into the joint is the right path for a patient? Who qualifies?
Well, they're often looking for persistent jaw pain or dysfunction that just hasn't responded to non-surgical treatments.
Like physical therapy or splints?
Exactly. Think limited mouth opening, painful clicking or popping sounds, or even episodes where your jaw locks up.
Okay.
And if you have chronic pain right in front of your ear and they can't rule out a problem inside the joint, a diagnostic arthroscopy might be considered just to see what's going on.
Is there a system for classifying these issues?
Yes, doctors use a system called the Wilks classification. It helps categorize these disorders based on things like how wide you can open your mouth. The MIO, maximum interincisal opening,
Right.
what kind of noises your joint makes, and what the imaging, like an MRI, shows. It ranges from, say, stage I, a simple click without pain, all the way up to stage V, which is severe degeneration with crepitation, a grinding sound.
Got it. But it's not for everyone, right? When would they not do these procedures?
Absolutely critical point. It's not appropriate for certain conditions.
Yeah.
Things like bony ankylosis, where the joint is completely fused by bone,
Okay.
or advanced fibrous ankylosis, where dense scar tissue severely restricts movement. Those usually require more extensive open surgery, like a total joint replacement.
Makes sense.
And naturally, if there's an active infection on the skin right where the surgeon needs to make the small punctures, that's a definite no-go. You wouldn't want to introduce infection into the joint.
Right, avoid spreading it. So the advantages seem pretty clear. No big incision, no facial scar, less risk of nerve injury compared to open surgery. It sounds incredibly compelling.
It is, definitely.
But like any advanced procedure, are there inherent trade-offs or common challenges surgeons face beyond just learning how to do it?
Absolutely. Beyond that steep learning curve for surgeons to master these really intricate techniques, there's also the cost. The specialized equipment isn't cheap.
Ah, yes. The practicalities.
Right. So while the benefits for the patient often clearly outweigh these factors, it's a constant balancing act for both the practitioner and, the healthcare system.
Okay, so let's move on to the patient. Before any procedure, there's this meticulous process of evaluation. It sounds like it's more than just a quick checkup.
Oh, much more. Our sources stress a systematic, problem-oriented approach. It starts with really listening to the patient's story.
The chief complaint.
Exactly. What is it? I can't open my jaw. Or, my joint clicks and it hurts. Sometimes it's even things like, I have ear pain or headaches.
Which might actually be coming from the jaw.
Precisely. Referred pain. They'll also delve into habits like clenching or grinding your teeth, what we call parafunctional habits, and any past traumatic events. Even seemingly minor ones from years ago that the patient might not immediately connect to their current jaw problem. Direct hits or even indirect whiplash-type injuries.
That's thorough. And what about the physical exam itself?
Well, beyond just listening, clinicians use objective measures. They'll measure how wide you can open your mouth, your MIO, and how far you can move your jaw side to side, your lateral deviations.
Checking the range of motion.
Right. They correlate any joint noises, that clicking, popping, or grinding with specific movements. And they'll carefully palpate or feel specific areas around the joint and muscles to assess pain.
Is there anything particularly interesting in the diagnostic tools?
Yeah, there's a clever diagnostic tool mentioned called Mahan's sign.
Hand sign.
It involves having the patient bite down on something firm, like tongue blades on one side. This loads or puts pressure on the working side condyle. Okay.
If that reproduces their specific pain, it's a positive sign and often points towards an orthopedic problem inside the joint, particularly in certain Wilks stages like 2, 3, and 4.
Interesting. Why not stage V?
Because in stage V, the disc is often perforated, so the condyle might actually move through the hole when loaded, potentially not causing the same distinct pain pattern. It helps pinpoint where the pain originates.
Fascinating detail. And imaging, you mentioned that earlier.
Crucial role. A panoramic radiograph, often called a panorex, gives a broad overview. It shows the condyles, those rounded ends of the jawbone and the joint spaces. You look for changes like flattening or bone spurs, osteophytes.
Kind of a screening tool.
Sort of, yeah. And then there's the MRI. That's really the gold standard for looking at the soft tissues, especially the disc.
Right, the magnetic resonance imaging.
Exactly. And what's fascinating about MRI isn't just the images themselves, but the surgeon's expertise in, let's say, rereading them through their own clinical and surgical lens. They bring their experience to the interpretation. So it's not just what the radiologist reports.
Often, the surgeon looks with a specific focus. For instance, an MRI showing the back part of the disc, the posterior band, sitting at maybe the 10:30 or 11:0 o'clock position when your mouth is closed. That's generally considered abnormal.
Okay.
Specific MRI sequences like T1 weighted views are paramount for confirming the diagnosis, the anatomy, while others, T2 weighted images, are better at showing inflammation like joint effusion, which is excess fluid.
I see. So it gives a really detailed picture.
It allows for a much deeper understanding of the cause of the TMJ issue. Our sources broadly categorize these causes into things like parafunction, those jaw habits.
Grinding, clenching.
Right, dentofacial deformities, so structural jaw issues, direct macrotrauma, a blow to the jaw, indirect macrotrauma like whiplash, and even systemic diseases like rheumatoid arthritis affecting the joint.
Okay, so once that diagnosis is crystal clear, we can really go inside the joint. Tell us about the arthroscope itself.
Yeah, the technology is pretty incredible. Our deep dive reveals the arthroscope is essentially a tiny endoscope. It's designed to extend the surgeon's eye directly into that intra-articular space.
Like a tiny camera going right in.
Exactly. Imagine seeing inside your own jaw joint in real time on a monitor. It's all thanks to advanced optics. They have specific characteristics like the field of view is actually reduced by about 40% when it's in fluid.
Oh, interesting.
So the optics have to compensate for that. They ensure image quality and even color accuracy, often white balancing to around 5,000 Kelvin, which is close to natural daylight, for a true view.
Wow. And this relies heavily on video now, right? Not looking through an eyepiece.
Oh, absolutely. Modern TMJ arthroscopy is fundamentally powered by advanced video technology. The advantages are immense.
Such as?
Well, improved sterility, for one. The surgeon is more comfortable, not hunched over an eyepiece. You get magnified, high-quality images displayed on a screen for the entire surgical team to see.
That seems important for coordination.
Definitely. And it provides invaluable documentation for teaching purposes and, medical legal records as well.
What about the scopes themselves? Are they getting smaller?
Incredibly so. Systems like the Biomet On-Point system use a tiny 1.2 millimeter 0-degree scope. That's about the size of an 18-gauge needle.
That's minuscule.
It really is. Others, like the Smith-Nephew system, boast HB 1080i resolution with a slightly larger 1.9 millimeter scope, often with a 30-degree angle for looking around corners, so to speak.
And they use specialized tools through other entry points.
Exactly. This precision extends to the specialized armamentarium, as the sources call it. You have cannulas, which are hollow tubes for irrigation and passing instruments through.
Okay.
Various probes for gently palpating tissues and manipulating them. Specialized biopsy forceps to take tiny samples if needed. And even something colorfully called a golden retriever for retrieving things.
Like if a tiny piece of an instrument broke off.
Precisely. A rare event, but they have tools specifically for that contingency.
And it's not just hand tools, right? You mentioned motorized shavers.
Correct. Motorized shavers, like a 1.9 millimeter whisker shaver, are designed with shields to protect the delicate articular surfaces, the cartilage. They efficiently cut and remove inflamed or excess tissue.
Very precise removal.
Very. Then there's electrosurgery. This uses high-frequency electrical current for either precise cutting or for coagulation, sealing off tiny blood vessels to control bleeding.
And lasers.
Yes, laser technology, too. The holmium.YAG, or HODAG laser, is highlighted in our sources as being particularly safe and effective for intra-articular procedures.
Why that specific laser?
Mainly because of its very limited penetration depth into tissue, only about 0.3 to 0.5 millimeters. This makes it ideal for things like an anterior release, freeing up the disc, or a synovectomy, removing inflamed joint lining without risking damage to deeper structures.
That controlled depth seems crucial in such a small space.
Absolutely, which brings up a critical question. Safety. How do surgeons ensure they don't accidentally damage vital structures in such a confined and delicate area?
Yeah, that's what I was wondering.
Our sources meticulously detail these danger zones. For example, when creating the main entry point, the fossa portal, surgeons have to be acutely aware of the neurovascular bundle nearby the auriculotemporal nerve. Superficial temporal vein and artery are only about 5 to 8 millimeters anterior to the tragus, that little bump in front of your ear canal.
Very close.
Very. And crucially, the dura mater, the lining of the brain, and the temporal lobe itself are immediately above the glenoid fossa, the socket part of the joint. Sometimes the bone separating them is only 0.5 to 1.5 millimeters thick.
Wow, incredibly thin.
Extremely thin. There's also a risk, if the scope is angled incorrectly, to the tympanum ossicles, the tiny bones in the middle ear and the middle ear space itself.
Goodness.
And for the other common portal, more towards the front, the anterior eminence portal, the main concern is the frontal branch of the facial nerve, which controls forehead movement.
So constant vigilance is key.
Constant, vigilant awareness of anatomy and instrument position is absolutely critical for preventing serious complications.
Okay, so once they're safely inside, the real diagnostic deep dive begins. You mentioned a diagnostic sweep.
That's right. It's like a precise, guided tour inside the jaw joint. The surgeon systematically examines 7 key anatomical areas.
What are they looking for?
They examine things like the medial synovial drape. Its appearance is apparently a good barometer of how much synovitis or inflammation of the lining is present. They look at the pterygoid shadow, which can have a telling purple tinge indicating vascularity.
Okay.
They inspect the retrodiscal synovium, the tissue behind the disc, the articular surfaces themselves, the eminence and the fossa, the articular disc itself looking for tears or deformation, the intermediate zone, and the anterior recess, the space in front of the disc.
So it's a comprehensive internal map.
Exactly. Identifying everything from inflammation to what they call creeping synovitis, disc fragmentation, thinning, and even perforations or holes in the disc or tissues.
And how do these visual findings relate to the patient's problem?
What's fascinating here is how these visual insights during the sweep directly correlate to specific pathologies. They're looking for those telltale signs of acute or chronic inflammation or the development of tough fibrous adhesions, basically,
Yeah.
bands of scar tissue that can tether structures and restrict movement.
Right. Sticking things together that shouldn't be.
Precisely. Or even rarer conditions might be spotted, like villonodular synovitis, where the joint lining grows abnormally thick, or synovial chondromatosis, where little balls of cartilage form within the joint.
Wow.
And importantly, they assess chondromalacia. That's the degeneration of the articular cartilage, the smooth gliding surface. It's often graded from stage 1, which is just some softening, up to stage 3, which involves crater formation and exposed bone underneath.
So they can actually see the level of wear and tear.
Yeah, directly see it, yes. And in really severe cases, there's a condition called arthrofibrosis. This is severe hypomobility, very limited movement due to extensive scar tissue. It can present unique challenges during surgery, sometimes with a whiteout where everything is covered in fibrillar tissue, requiring the surgeon to carefully lise or cut through it just to create some working space.
Okay, so once they've mapped out the pathology, the operative part begins. What are the common procedures?
For many patients, especially with inflammation and maybe some early adhesions, a lysis and lavage is performed.
We mentioned that earlier, breaking up adhesions and washing out the joint.
Exactly. Physically breaking up those scar tissue bands and flushing out all those inflammatory mediators, the chemicals causing pain and damage. This alone often resolves acute symptoms in a significant number of patients, maybe 65–70%.
That's quite effective for a relatively simple step.
It can be. But for more complex issues, more involved techniques come into play. We're talking about precise lysis or cutting of specific adhesions, maybe in the anterior recess, the posterior recess, or even laterally using those tiny probes, shavers, bipolar electrocautery, or lasers.
Targeting the specific problem areas identified in the sweep.
Precisely. And interestingly, our sources mention ongoing studies exploring injecting botulinum toxin A.
Botox in the jaw joint.
Well, directly into a specific muscle near the joint, the superior head of the lateral pterygoid muscle using arthroscopic guidance. The idea is to help manage chronic facial pain potentially related to muscle hyperactivity. Still experimental in this application, but interesting.
Very interesting. What about issues with the disc itself, if it's displaced?
Right, so tying this to the bigger picture, a primary goal if the disc is out of place is to restore the normal relationship between the condyle, the jawbone, and the disc.
Getting it back where it belongs.
Essentially, yes. This often involves anterior release procedures first to free up a disc that's stuck or tethered anteriorly, and then often followed by a discopexy, which is a procedure to stabilize the disc in a more normal position.
How do they stabilize it arthroscopically?
It's a meticulous technique. Typically, it involves passing a suture, a stitch, through the posterior part of the disc, and then securing that suture outside the joint capsule, often to the bone or strong tissue nearby, to hold the disc back.
Okay, kind of anchoring it.
Exactly. The author of one of our main sources actually pioneered a more advanced technique called arthroscopic rigid disc fixation. This used tiny cannulated screws or absorbable smart nails to fix the disc quite rigidly.
Wow, screws inside the joint.
Tiny ones, yes. It was a 3-puncture technique, quite complex, but it offered increased stability and allowed for immediate, aggressive physical therapy afterwards, which was a big advantage. But what's interesting about this innovation is that while it offered those advantages, it also seemed to highlight a common complication more frequently. Post-operative issues with the patient's bite, their occlusion.
So maybe too rigid.
Perhaps, or the positioning was just that critical. This actually led the author to refine the more traditional semi-rigid suture discopexy technique, making it more robust and reliable. It kind of proves that sometimes even very advanced innovations can lead you back to refining existing solid methods for potentially even better overall outcomes.
A fascinating example of refinement in surgery. So what does this all mean for the patient after the procedure? The surgery is done, but the journey isn't over.
Not at all. Post-operative management is absolutely critical for success. It starts right there in the recovery room.
So,
The surgeon guides the anesthesia team to ensure a smooth, controlled awakening or extubation. Ideally, the patient is still a little drowsy, semi-obtunded,
why is that important?
to prevent sudden, strong muscle spasms or clenching as they wake up, which could potentially compromise the delicate work just done inside the joint.
Protecting the repair.
Exactly. Then comes a careful regimen pain management, often starting with something like Toradol intravenously, then maybe oral anti-inflammatories, and usually a course of antibiotics as a precaution against infection.
Okay. And what about getting back to normal function? Eating, moving the jaw.
This leads us to ask that very question. Diet is strictly controlled initially. It usually progresses from full liquids for a period, then to soft foods.
Oh, the restriction.
To allow for what the sources call intra-articular settling, basically letting the joint structures heal and adapt to their new state without too much stress from heavy chewing.
Makes sense. And physical therapy.
Absolutely crucial. Physical therapy, or PT, often begins quite soon after surgery, following what they term an arthroscopic cascade of rehabilitation stages. It's very structured.
A cascade. Tell me about the stages.
Okay, stage I typically focuses on reducing pain and swelling, maybe using ice or heat, and involves very gentle, limited range of motion exercises. The goal here might be to achieve, say, 35 millimeters of mouth opening comfortably.
Starting slow.
Very slow and controlled. Then, stage 2 introduces more aggressive stretching techniques, maybe some intraoral manipulation by the therapist to really work on increasing that range of motion further.
Getting more movement back.
Right. Stage 3 then emphasizes muscle re-education. This is about correcting abnormal movement patterns that might have developed because of the TMJ problem. Interestingly, they sometimes discourage patients from watching themselves in a mirror during exercises at this stage.
Why no mirror?
The idea is to rely more on internal cues, proprioception, feeling the movement correctly, rather than just visually trying to achieve an opening, retraining the brain-muscle connection.
Fascinating. And the final stage.
Stage 4 focuses on building strength and endurance in the jaw muscles, returning patients progressively to full function and eventually back to their normal pre-morbid diet. This whole staged approach is vital for preventing fibrosis, excessive scarring, and maintaining the mobility gained from the surgery.
It sounds like the PT is just as important as the surgery itself.
In many ways, yes. Patient compliance with the post-op regimen and PT is a huge factor in the long-term success.
Okay, while these procedures sound transformative, we do need to talk about potential complications. No surgery is entirely without risk.
That's true, and it's important to acknowledge our sources detail a range of possibilities. Some are more common and usually temporary, like transient facial palsy.
Weakness in the facial muscles.
Yes, potentially affecting blinking or smiling due to bruising or stretching of branches of cranial nerve 7, the facial nerve. This usually resolves on its own within, say, a week up to maybe 6 months in rare cases. Nerve paresthesia is also possible. Temporary numbness or altered sensation around the ear or temple area from irritation of branches of cranial nerve V, the trigeminal nerve. Again, usually temporary.
And more serious, rare things.
Very rare, but possible if technique isn't meticulous, are things like tympanic membrane perforation, a hole in the eardrum, or even damage to those tiny ossicles, the bones in the middle ear, if the scope is advanced too deeply or angled incorrectly.
Right, back to those danger zones.
Exactly. The critical takeaway, though, is that surgeons performing these procedures are highly trained to identify and manage these risks, and the prognosis, even if a minor complication occurs, is often excellent.
How do they minimize these unforeseen issues during the surgery itself?
Well, what's fascinating here is the sheer attention to detail required. Things like minor scuffing of the fibrocartilage surface during scope manipulation are actually pretty common just from instruments moving in a tight space, but can be minimized with careful, gentle technique.
Okay, that sounds less concerning.
Right. More serious, but again, extremely rare, issues like damage to the maxillary artery, a major artery near the joint, which could potentially lead to an arteriovenous fistula.
A connection between an artery and vein.
Yes. Or glenoid fossa perforation, actually making a hole through that thin bone into the cranial space, potentially causing cerebrospinal fluid leaks. These have strict protocols for prevention. It comes down to the surgeon's continuous awareness of cannula depth and instrument direction at all times.
Constant monitoring.
Constant. Even instrument failure, like the tip of a shaver breaking off, though very infrequent with modern instruments, has a clear protocol. Having backup instruments ready and using imaging like fluoroscopy if needed to locate and retrieve any loose bodies, preparedness is key.
It sounds like safety is paramount.
Absolutely.
So as we start to wrap up our deep dive, our sources emphasize a powerful philosophy in TMJ management, this arthroscopic cascade. Can you explain that concept?
Yeah, it's really about a progressive, thoughtful approach to treatment. If we connect this to the bigger picture, The author's strong belief, reflected in the sources, is that a TMJ surgeon should not, quote, indiscriminately stampede to the final treatment, meaning something like a total joint replacement.
Don't jump to the biggest intervention first.
Exactly. The arthroscopic cascade aims to postpone that endpoint procedure, ideally indefinitely in many cases, by managing the existing problem effectively with these minimally invasive steps first. Lysis and lavage may be discopatigi, using the least invasive effective treatment for the current stage of the problem.
It's about managing the conditions step by step.
Precisely. And it's also about knowing one's limitations. The author even playfully quotes, "Dirty Harry, a man's got to know his limitations."
Oh. In the context of surgery.
In the context of recognizing what arthroscopy can and cannot achieve for every single patient. It's about managing a condition, often very successfully, but not necessarily claiming to cure a degenerative disease in all its aspects. It's realistic optimism.
That makes a lot of sense. And the field itself is still moving forward.
Oh, absolutely. The field continues to evolve. Surgeons are constantly refining techniques, pushing for even smaller, more accurate instruments, maybe even instruments that can do multiple tasks. Grasp, cut, coagulate, all through one tiny device. It's really a testament to the dedication to improving patient outcomes.
So thinking about all this, what does it really mean for someone listening? We've journeyed from how TMJ care evolved historically to this intricate dance of diagnostic sweeps inside the joint, the precise surgical interventions like stabilizing the discopexy.
Right.
And then that meticulous path of post-operative recovery with the physical therapy cascade. It's clearly a field demanding incredible precision, constant innovation, and an unwavering commitment to improving quality of life for people suffering from TMJ disorder.
It really is.
Just think about the profound impact that these tiny, minimally invasive procedures can have on someone's daily life, restoring basic functions like eating comfortably, speaking without pain, just living without that constant ache.
Yeah, the quality of life improvement can be huge. And this whole discussion raises an important question, I think, as we look forward. As technology continues to miniaturize and these surgical tools get even more refined, how much further can we actually push the boundaries of minimally invasive procedures? Will we reach a point where open TMJ surgery becomes an absolute rarity, even for the most complex conditions?
That's a provocative thought.
And what new frontiers in healing, maybe faster recovery, better long-term joint health, might these advancements unlock in the next decade or so? It's an exciting space to watch.
Definitely something to think about. Keep exploring, keep learning, and thank you for joining us on this deep dive into TMJ, arthroscopy, and arthrocentesis.
Thank you.
Until next time, stay curious.